So let us talk about anatomy and pathology relevant for endoscopy nurses and technicians. So I would like to present a series of cases and explain to you the relevant anatomy and physiology that you need to understand. So let us take a patient with a heartburn. This is quite common, and when you think about a patient with heartburn, you should be thinking about problems with the esophagus. And when it comes to esophagus, you need to understand that the esophagus goes through the chest and through the diaphragm and enters the stomach. So let us look at the anatomy of the gastroesophageal junction. So here is the detailed anatomy of the gastroesophageal junction. You have the esophagus lined by the squamous lining, goes through the diaphragmatic crura or diaphragmatic muscle, and the opening in the diaphragm is known as hiatus, and then it enters the stomach. You know that stomach secretes acid, and when acid comes up through the lower esophageal sphincter into the esophagus, it can create what we perceive as heartburn. So how do we prevent acid from coming up into the esophagus all the time? So you have to think about the diaphragm and the muscle around the esophagus, that's the crura, and the lower esophageal sphincter and a valve, that is the flap valve. So the crura of the diaphragm acts like an external sphincter, and the lower esophageal sphincter and flap valve act like an internal sphincter. These two structures constitute the anti-reflux barrier, and this anti-reflux barrier prevents the acid from coming up and creating what we call heartburn and gastroesophageal reflux disease. So now, when you have a patient with heartburn and gastroesophageal reflux disease or GERD, you need to understand when you perform endoscopy certain structures. The first structure that as you go down the esophagus into the stomach is we identify the gastroesophageal junction. We also try to identify the diaphragmatic pinch. So as you go down the esophagus, you notice whether there is a contraction, circular contraction of the lower end of the esophagus with each respiration because of the diaphragm pinching on the esophagus. So here we see a normal gastroesophageal junction. So the esophagus has gone through the diaphragm into the abdomen and entered the stomach. Normal gastroesophageal junction. So one of the common things that predisposes to acid reflux is hiatal hernia. In hiatal hernia, what happens is the stomach actually protrudes through the diaphragmatic hiatus into the chest, and the GE junction has moved from below the diaphragm up into the chest. So you see the green color, that's the GE junction. The red color, the diaphragmatic hiatus. When you do an endoscopy, how do you identify diaphragmatic hiatus and GE junction? So here you have the lower end of the esophagus, and the diaphragmatic pinch or the going through the hiatus keeps contracting at that area, closing and opening. That's the diaphragmatic hiatus. Compared to that, you notice the gastroesophageal junction, the stomach folds have come up a little bit higher, marked by the green outline. So you know that the patient has a small hiatal hernia. So important to identify whether the anti-reflux barrier is working properly or not when you do endoscopy. Next is you identify whether there is damage to the esophagus from the acid. So when there is damage to the squamous lining by acid coming up into the esophagus from the stomach, it causes erosive esophagitis. So there are 4 gradations. We will talk about the worst one, that is Los Angeles grade D. When you see lots of damage, that is almost circumferential. That is LA grade D. Compared to this, a milder grade is LA grade C. You still have a lot of damage, but the damage is not circumferential. And then compared to that, LA grade B, these are longitudinal streaks of erosions more than 5 millimeters. And when it is less than 5 millimeters, it is LA grade A. So we talked about esophagitis, grade of esophagitis, and we talked about whether the patient has hiatal hernia or not. Sometimes you may see a patient where the patient has been complaining of a lot of heartburn, but when you do endoscopy, it looks completely normal. Is this because of non-erosive reflux disease or NERD? How do you figure out whether the patient is getting a lot of acid into the esophagus, but the esophagus lining is pretty strong and not getting damaged? So you measure the acid coming into the esophagus by putting a probe. You can attach a probe that is called the Bravo pH capsule. So it sends the signals whenever it senses acid to a recorder that the patient carries for 4 days. And when the acid is coming up too much, then into the esophagus, then you diagnose the patient has non-erosive reflux disease. So we talked about acid reflux in detail. Sometimes acid reflux not only damages the esophagus, but it replaces the lining from the squamous esophagus lining to the stomach lining with some intestinal type of cells. That is known as Barrett's esophagus. So let us talk about how do you mention whether the patient has Barrett's esophagus or not. So we need to take some measurements, and these are the measurements that the endoscopist takes. So when you go down the esophagus, you measure where the diaphragmatic pinch is, or the hiatus. Here is the diaphragmatic pinch. You watch whether there is movement with each respiration, whether the lumen becomes smaller or not. So for example, this is at 40 centimeters. We know that the esophagus goes through the diaphragmatic hiatus and enters into the abdomen and then becomes the stomach. And then you look at gastroesophageal junction. Here it's marked by the arrow. It is in this case again at 40. Sometimes with respiration it can move up or down 40, 41 centimeters. So this is a normal GE junction with no hiatal hernia. So now let us look at what is a hiatal hernia. Here the stomach prolapses up into the chest through the diaphragmatic hiatus. So here you see the scope. You measure where the diaphragm pinches. That is at hiatus is at 40 centimeters. And then as you withdraw the scope, you look at where the stomach folds end, that is the gastroesophageal junction. Hiatus was at 40 centimeters, gastroesophageal junction was at 35 centimeters. That is hiatal hernia of 5 centimeters. So you'll notice that the hiatal hernia is 5 centimeters. Then as you come up and measure where the squamocolumnar junction is, where the beefy red stomach lining ends and the nice pink lining of the esophagus starts. Here the squamocolumnar junction is measured at 30 centimeters. So what it means is that difference between the gastroesophageal junction and the squamocolumnar junction, columnar lined esophagus, is Barrett's esophagus. In this case, it is 35 minus 30, 5 centimeters. 5 centimeters of Barrett's esophagus. So we noted a 5 centimeter hiatal hernia and a 5 centimeter Barrett's esophagus. And then you may see that as you pull your scope back, you may see tongues of lining, not circumferentially, but coming up into the esophagus. In this case, the tongue was at 28 centimeters. So what it means is the Barrett's has a circumferential length up to 30 centimeters and tongues going up to 28 centimeters. So circumferential 5 centimeters from the GE junction and 7 centimeters maximum extent. That's why it's called C5M7. So let us summarize. Here is a patient with acid reflux that has hiatal hernia of 5 centimeters and a Barrett's esophagus, circumferential extent 5 centimeters, maximum extent of 7 centimeters. All these measurements are very important, and these are the measurements that endoscopists call in when they are doing the endoscopy. So now we move to a patient with vomiting of blood, or maybe patient with varices. So you need to understand the anatomy of the esophagus, stomach. So here I'm going to show you. You have the spleen, you have the liver, you have the portal vein, PV, splenic vein, SV, superior mesenteric vein, SMV. So let us see the flow. Splenic vein flowing into the portal vein. Superior mesenteric vein joins the splenic vein, forms the portal vein. From there, into that portal vein, the left gastric vein that drains the esophagus and stomach enter. On the right side, you see the short gastric vein. So all this blood goes into the liver. And then when you look at the liver and try to see the microscopic structure of the liver consisting of a lobule, it has a very unique structure. In the center, there is a vein called central vein. In the periphery, there are portal triads. So the blood from the portal vein goes into the portal triad. From there, it goes through these small veins, sinusoids, enters the central vein. And all the central veins end up draining through the hepatic vein into the inferior vena cava and into the right atrium. So that is normal flow of blood. In cirrhosis, what happens? There is a lot of damage. The structure is distorted. The blood flow from the portal triads to the central vein becomes very slow. And there is resistance to flow, and then it results in backflow, and the backflow leads to varices. So these varices could be esophagus or gastric fundic varices. So let us look at the anatomy. Okay, lower esophageal area and close to the G junction and stomach. So here we go. So as you can see here, the blood is going through periesophageal veins, and then from periesophageal veins through the perforator veins into the esophageal varices. When you look at it, the perforator veins are maximum in the last or distal 5 centimeters of the esophagus. If you get rid of those perforator veins, the maximum density, you are going to be very effective in eradicating varices. That's why you start your banding close to the GE junction, and then the last distal 5 centimeters of the esophagus. That's the basis. You should band close to the GE junction. Now let us talk about a patient who's saying, I'm having difficulty swallowing. So let us look at what is normal swallowing. So once you swallow, as the food enters into the esophagus, it has to go through a lumen that has to be open for it to enter into the stomach. And then you also need to understand that if the lumen becomes narrow, then food is not going to go down, and the patient says, I'm having difficulty swallowing. So that's one. The other one is the esophagus has to contract, should have peristalsis. And as the peristalsis wave comes from the top end of the esophagus to the lower end of the esophagus, the lower end of the esophagus and the esophageal sphincter should relax so that it can allow the food to get into the stomach. So when all these things are going on well, there is normal peristalsis and normal relaxation of the lower esophageal sphincter, you say that the motor function of the esophagus and lower esophageal sphincter is intact. On the other hand, if the peristalsis is weak or absent, or the lower esophageal sphincter does not relax appropriately, then you say that the motor function is impaired or abnormal. So let us talk about it. Whenever somebody has difficulty swallowing, you think about, is there a problem with the lumen narrowing, or is there a problem with the muscle dysfunction? No peristalsis or inadequate relaxation of the lower esophageal sphincter. So achalasia, muscle doesn't work. Okay. So let's talk about problems with the lumen narrowing. It's not uncommon. You have an older patient, he says, I'm having difficulty swallowing. When I eat bread, I get into trouble. That you may see like what is called Schatzki's ring, and sometimes they may come with food bolus obstruction. You heard about that. Then you may have somebody who has been having acid reflux for a long time, lot of heartburn, and then they have difficulty swallowing. Then they have what is called peptic stricture. In somebody who has a lot of difficulty swallowing, they're losing weight, and they're getting worse and worse, that is cancerous stricture or malignant stricture. So let us talk about endoscopy in a patient with esophageal stricture. So here is a stricture. It is relatively short and straight, and a typical example is a benign peptic stricture. It is what we call simple stricture. A benign peptic stricture is a classic example. All you do is you can dilate with whatever you want for short straight strictures, typically with a balloon. Or you could use a bougie. On the other hand, here is a stricture. As you can see, compared to the previous stricture, this is long and tortuous stricture, typically seen in cancer or corrosive strictures. This is known as complex stricture. Example, malignant stricture. In this one, you want to dilate with the help of a guidance, either with a guide wire or under fluoroscopy. So, now that you saw a patient with cancer, what do? You biopsy, and if it turns out to be cancer, then we send them for PET scan or a PET and a CT scan. Make sure that the radiologist says the cancer has not spread throughout the body into the lungs and to the liver or metastasis. Then you bring them back for endoscopic ultrasound. This actually helps you stage whether the cancer has spread locally or regionally, not distant, a local regional staging of cancer. So let us look at the when the ultrasound is done, what do you see? You see a cross section of the esophagus. And as you go down, you may see that the tumor has gone into the wall of the esophagus. So to understand better, let's talk about the normal anatomy of the esophagus on cross section. So lumen, mucosal lining, submucosa, where you have blood vessels and nerves, muscularis propria, that's the one that allows you to have contractions or peristalsis, adventitia. You know, the esophagus lies close to the aorta. So keep this diagram in mind, and then we will look at staging of cancer. So here is cancer that's gone into the submucosa, that is T1. If it touches the muscle and goes into the muscle, that is T2. If it goes through the muscle, that is T3. And then if it touches the adjacent organs, like an aorta, that is T4. So we have learned a lot about patients coming in with heartburn, patients coming in for Barrett's esophagus, patients coming in with vomiting of blood or hematemesis, varices, patients coming in with dysphagia, patients coming in for cancer staging. And this anatomy is very important so that when you're assisting your physician, you have a better understanding of what is going on in his mind. I hope this is helpful. Thank you.